Good afternoon, good evening, everybody. I'm Paul Mellmeyer, and I'm the Vice President of Public Policy and Advocacy at the Muscular Dystrophy Association. And we're very pleased to be joining you this evening to talk about some ALS policy updates. Of course, May is ALS Awareness Month, so no better time to be bringing you some updates on what's going on, largely in Washington, D.C., of course, with our focus with ALS. So, why don't we get started and look at what we'll be talking about today as I move to the next slide. Here we go. So, of course, as we always do, we'll start with a few introductions and housekeeping items, just so you know who we are and know how best to interact with us as we are bringing you the information today. From there, we're going to start with an update on Act for ALS. Of course, major piece of legislation passed for not only those with ALS, but those with neurodegenerative diseases more broadly back in December of 2021, and there's been a lot of activity since then. So we want to update you all on what's been going on with the Act for ALS and the programs that Act for ALS commissioned about a year and a half ago. From there, we're going to transition over to talking about a new initiative that's going on up in Congress right now, and that's to actually increase reimbursement and coverage, and then hopefully from there, subsequently access to multidisciplinary care for those with ALS. And we're very grateful to have Dr. Terry Hyman Patterson with us to talk further about her practice and why multidisciplinary care is so critical to those with ALS, and why greater access to that care is critical. From there, we'll move into the legislation, and we'll be talking about exactly what's going on up on Capitol Hill with the legislation, and how you can be helping us, helping the entire ALS community, just a little ways down the road. So let's start with just a couple housekeeping items before I introduce you again to those who are with us. So just as a reminder, perhaps some of you are new to our platform here, but a couple buttons that you might want to know to push in case they could be helpful. So first of all, on the bottom left side of your screen down there, you see a closed captioning button, that little CC. So if you could use closed captioning, it's down there to the bottom left of your screen. Over on the right side, if you are hoping to ask us a question, and we certainly do encourage you to ask us questions, and we'll be doing our best to, in particular, answer those questions at the end of our hour together, but we might sprinkle in a couple during the presentations as well. But to ask us a question, what you should do is go over to those three little dots on the right side of your screen there. You can see the arrow pointing towards them on the image here. Click on that and go to the Q&A. Q&A is actually the best place to be submitting your questions. So myself or Dr. Hyman Patterson or Joel Cartner, who's also joining us this evening, will be able to give you an answer to that question. So please send in your questions in the Q&A box there, and we'll get to them in the program. Okay, so why don't we meet the panel here? You're joined by three of us. I've already really given you the introduction to myself. I lead the public policy and advocacy team here at MDA, and I've been here now for several years, including through the very first idea, and then the creation, the authoring, and then of course the passage of the Act for ALS. So that will be my focus for this evening, giving you an update on where things stand there. But then I'll be turning it over to Dr. Terry Hyman Patterson, who is a professor of neurology and director of the MDA ALS Center of Hope at Temple University, Lewis Katz School of Medicine. And then also Joel Cartner, who's MDA's director of access policy, will be giving the legislative perspective on where things stand up on Capitol Hill on the initiative on multidisciplinary care. But before we get to Dr. Hyman Patterson, and before I turn it to Joel after her, we want to, again, give you an update on where things stand with the Act for ALS. So perhaps this might be some new legislation to you. This was really quite the focus of many, not only in the ALS community, but actually the entire rare neurodegenerative and rare neuromuscular disease communities, particular back in 2021, as the effort to get this passed out of Congress was really quite vociferous. In fact, actually, in that summer of 2021, Act for ALS was the most widely sponsored piece of legislation in the entire Congress, which was the most popular piece of legislation in Congress. And sure enough, it did pass and was signed by President Biden, who you see on the right side of your screen here signing the bill in December of 2021. So really, there are four main components of this legislation. There was, and still is, of course, the NIH ALS Expanded Access Grants Program. and then 3 programs that are focused on rare neurodegenerative diseases more broadly. There is a public-private partnership commissioned in which entities inside and outside of government would be joining together to try to tackle drug development issues when it pertains to rare neurodegenerative diseases. The law also commissions a regulatory action plan from FDA on how FDA is going to be moving forward with actually innovating its regulatory approach towards ALS and rare neurodegenerative diseases. And then finally, a grants program that FDA oversees to actually fund research that is specifically tied to clinical development within not just ALS, but also rare neurodegenerative diseases more broadly. So let's talk about what's been going on in each of these. So first, to start with the NIH Expanded Access Grants Program, it's had 2 rounds of funding thus far. It received $25 million in funding in the spring of 2022, and then for fiscal year 2023, the one that we're in right now, it actually received $75 million worth of funding to actually move forward with the Expanded Access Grants Program. The first round of funding was completed last year. And actually, some exciting news just about a month and a half ago. You see kind of the press release title there on the right side of your screen. The very first patient was dosed with a drug actually in the Healy trial that successfully received an expanded access grant from the NIH last fall and used that funding to actually now dose an additional individual with one of the therapies within the Healy platform trial. And ostensibly, this individual perhaps wouldn't have otherwise been able to obtain that therapy. So there is the expanded access grants program at the NIH working in real time, if you will, after the law was passed and now implemented at the NIH. But that was just the start. We're now in the second round of funding of this effort, and as I already alluded to, there's actually more money this time around. Rather than 25 million, there's 75 million to potentially fund expanded access grants programs at the NIH. And we're right in the midst right now of the application period. It was back in January, I believe, the NIH, and specifically it's the NINDS, the National Institutes of Neurological Disease and Stroke. They released the call for proposals, if you will, in January, and accepted letters of intent. And it was actually just on May 1st when applications were due to NIH for companies or trial sites or whomever is eligible to actually obtain an expanded access grant. That deadline was just actually a few weeks back for these entities to apply for an expanded access grant from the NINDS. Now, for the remainder of this summer, NIH will be looking at these grants. They're going to be reviewing them. They're going to ensure, of course, that they qualify. And then we know that it's NIH's intent to actually then announce the next round of grants by October 1st of this year, with then hopefully the money reaching the trial sites, reaching the companies by the end of this year. So again, either by the end of this year or early next year, additional individuals will be able to be dosed via an NIH-funded expanded access grant program. So, one thing to actually note as a way to get involved, right now, NIH is actually looking for individuals with ALS to participate on an advisory committee, essentially, to look at some of the grants that are coming into NIH or have already come into NIH. They're looking for individuals essentially as we speak. So, when I pause here momentarily to turn it over to Dr. Hyman Patterson, I'll put a link in the chat for you all to see in case you're interested in exploring that for yourself, in case you'd like to potentially be a reviewer for this program to ensure the applications align with what the ALS community would be looking for. So the second update I want to give is on the second component of the Act for ALS, and that's the Rare Neurodegenerative Disease Public-Private Partnership. And this was, again, commissioned as part of the law, and it required FDA, NIH, and their parents' department, if you will, the Department of Health and Human Services, to create this public-private partnership. And it was actually just in September of last year that they announced that it's the Critical Path Institute that is officially being brought on board to coordinate this effort. Critical Path Institute works routinely with especially the FDA, but other agencies in the federal government as well. And they're very familiar with crafting such public-private partnerships or consortia of stakeholders to really come together to try to tackle some of the most challenging aspects of drug development. in this case, of course, for rare neurodegenerative diseases. So they actually have already been doing some introductory meetings. We've attended several of these in the winter as well as the spring of this year. And what they're doing right now is really trying to kind of scope what they should be prioritizing, because there's obviously a lot to get done in this area. And so what they're doing is they're going on a bit of a listing tour, if you will, to hear from patients, to hear from advocacy organizations, to hear from clinicians, to hear from biotechnology organizations, really any stakeholder who has an interest in this effort. They want to know how this effort can be prioritizing so that they're really truly targeting those things that the stakeholder community hopes that together we'll be targeting. So they have continued to invite any and all stakeholders to join and discuss them. So in case you haven't been able to make one of these webinars, we know that they're going to have more in the future, and they also likely have recordings of the ones that they've already held. If you're interested in actually joining this or knowing more about this effort, which again is one of the main components of the Act for ALS, their email here is on the screen. It's cp-rnd@c-path.org to learn more. The third component of Act for ALS to provide an update on is the FDA Action Plan for Rare Neurodegenerative Diseases. And this, again, commissioned as part of the Act for ALS, is FDA essentially outlining how FDA wants to innovate over the next couple of years pertaining to ALS and all rare neurodegenerative diseases. So they actually published this almost a year ago at this point. They published this either at the very end of June, but I think it actually drifted into July when they published this last year. And what they put forward was a phased approach of initiatives, essentially, again, aimed at speeding development and regulatory review of therapies. They're starting with ALS. They're going to start focusing specifically on ALS, but from there, after having focused on ALS, they want to expand into other rare neurodegenerative diseases using the example or model of ALS, if you will, that they will have already started at that point. So it's a very meaty document. It's really heavy on its regulatory lingo, if you will. But for those of you who are up for it, definitely encourage you taking a look just to see what FDA has planned for this year, for next year, and actually I think all the way through 2026. Finally, the last program with an Act for ALS I wanted to mention that has also seen some progress is the FDA Rare Neurodegenerative Disease Grants Program. And again, this is FDA's opportunity to fund innovative efforts to really move the ball further down the field when it comes to bringing new treatments to those with ALS and rare neurodegenerative diseases more broadly. So last year, as part of their fiscal 22 funding, they actually funded 5 studies under this program. 3 are natural history studies within ALS, within myotonic dystrophy, and within a rare ataxia. And then also 2 additional studies that are focused, the first on converting ALS-FRS, the ALS-FRS test, essentially into a home-based assessment, a remote assessment, to allow folks with ALS to potentially participate in clinical trials and have their endpoints measured using ALS-FRS, but rather having to go into the clinic, they can potentially do so from home. So could be very impactful for those with ALS, hoping to participate in trials, but maybe not wanting to go to clinic as often as they are. Sorry, Dr. Hyman Patterson. But sometimes folks, might want to stay in the comfort of their own home if they're still able to participate in their clinical trial. From there, also FDA funded a study on a landscape analysis of brain-computer interface-focused patient preference studies. That goes way over my head on what that is, but FDA is funding it to try to learn how this could be impactful with an ALS. And that's just in the very first year of funding. They have new opportunities actually available right now. The deadline, actually, I shouldn't say right now because the deadline's today. Gosh, I hope no one was looking at this and hoping to apply at this point because you got a couple hours. But they are taking applications up through today. And actually, in particular, they've named one that you can see on the bottom right of your screen, which I'll just read it out again. The Systemic Review of Clinical Outcome Assessments for, again, brain-computer interface devices in ALS. So this is, again, FDA trying to move the ball down the field in targeted ways, trying to fund efforts targeting these very things. And all of this, again, because of Act for ALS. So as you can see, Act for ALS wasn't just about the legislative effort and wasn't just about kind of getting that ball across the end line, the end zone line, if you will, for getting the bill signed into law by President Biden. Look at all this work that's been happening since. Obviously, a lot more work to be done, but some really exciting stuff just in the first year or so of the law's existence. So with that, we're going to transition away from Act for ALS and into another big initiative that's happening right now. And with that, I'm going to turn it over to Dr. Terry Hyman Patterson, who's been very involved not only in this initiative, but knows everything there is to know about running a multidisciplinary care clinic. So, Dr. Hyman Patterson, I turn it to you.
Thanks very much, Paul. I know that most of you listening to this know what a multidisciplinary clinic is, and I think all of this is so exciting. The progress we're making towards really finding treatments and assistive technologies like brain-computer interface, very exciting. But we got to get back to the the mundane, so to speak, but it's in the trenches, taking good care of you with the tools that we have now. And that's critical. And even though I don't have a magic bullet yet, uh, good multidisciplinary care can truly make a difference in quality of life and in survival. So, can I have the next slide? So, multidisciplinary care, what is it? Well, I think many of you out there know it's not just seeing the doctor, it's seeing the team of people who are going to help make things as good as they can be, help your quality of life, help address your functional needs and your emotional needs. And so when you go to a clinic visit, many of you know you see not only the physician, but maybe the nurse coordinator. You might see the research team, certainly nutrition, mental health, case management, all working to get you the things you need and figure out. And then physical therapy and occupational therapy aimed at, getting you mobile and safely mobile and maximizing your function every step of the way. And as part of physical therapy and occupational therapy, assistive technology is really important. And then respiratory therapy, I mentioned before that good multidisciplinary care can make as much a difference to your quality of life and survival as the medicines we have out there now. And respiratory therapy, the proper implementation of BiPAP can do more for making you feel better and live healthier and longer than anything else we probably have. Of course, speech and language. And it's not only the team in clinic, but there's another team. You have your family and friends. And I always say ALS is a family disease, and we at the clinic are your extended family. But your family plays a huge role, and other specialty physicians like the pulmonologist or rehab. And then, of course, we have to work through our case management social worker with home care and community organizations. So it takes a village. It takes this multidisciplinary approach. Paul, next. And so when I look at the community of ALS centers, I sent out a survey to 60 of my, well, 100 of my colleagues, and I got more than 60 responses. And, I asked the question, what do you have at your clinic? What's your multidisciplinary picture look like? And you can see that virtually all the clinics had physical therapy, occupational therapy, and speech and language, BSLP, speech and language pathologist. And respiratory therapists also were way up there at 90%. And then as we go down, in the 80%, the nutrition and nurse coordinator. Research was a big effort. And you can see, why we feel it's really important to not only give the best care, but to push clinical research, be it clinical trials or understanding the disease better. And across the community, that's a huge push. And 66% of clinics also have research personnel in the clinic. Case management, we all know, fighting for the drugs, getting those pre-auths, getting those peer-to-peers done, getting you the services that you need. Case management becomes a critical import. As in my clinic, we think mental health is really important. We even do home visits for mental health. And more genetics is really becoming important. And I think that statistic is going to go up over the next 5 or 10 years as we learn more about ALS one gene by one gene. I mean, there's now been more than 40 genes implicated as causal in familial ALS, and sometimes found in the sporadic population. And those genes are teaching us about pathways that are important in driving the disease itself, and therefore providing targets for new treatments. And then, of course, some clinics actually have the rehab and lung doctors right there. Next slide. So, how do we care for people with ALS? The first order of business is compassion and hope. And that starts from giving the diagnosis and talking about what to expect. But the multidisciplinary care is really what makes the difference, and why you can sit there at the initial visit and talk about hope and keeping people independent, because our whole goal is to find out what's important to you and enable you. It's not to disable you. We need to enable you and maximize your independence and quality of life and prolong survival. So it's, managing the disease with the medications. We now also have Relyvrio, Riluzole, and Radicava, and of course everybody knows that Qalsody or Tofersen was just approved, and so very exciting time, absolutely. Symptom management is critical. That goes to quality of life. And then independence, mobility, activities of daily living, communication, things that are so important to people living with ALS. We have to address those. And then respiratory and nutritional support, implementing BiPAP, and feeding tube if necessary at the appropriate time can make a huge difference in survival as well as quality of life. I think emotional support and education are so important, and that's why we need so many people in the clinic, is to really do our best to make a difference to people living with ALS, and really give you the independence and quality of life that you deserve. Next slide. And the multidisciplinary care is really the central point of that. And people recognize this. It's part of the practice parameters as defined by the Academy of Neurology. It's part of the quality care metrics defined by the Academy of Neurology. In other words, this is what quality care is for ALS. And it's been shown that multidisciplinary clinics prolong survival, promote independence and quality, the same things that you've been hearing me say throughout this sort of mini talk. And also we reduce complications like falls and injuries, pneumonias, ER visits, and hospitalizations by being proactive and really having a cohesive, careful, multidisciplinary approach. Next slide. So what are our challenges? Well, during COVID, we really learned a lot about telemedicine, and to be quite honest, telemedicine persists even as COVID pandemic has, I don't want to say disappeared, but is reduced. And many of our folks feel find the convenience of telemedicine, which is certainly important as the disease progresses, but even for people who are traveling and want to maintain their care. Maybe they're on vacation and their appointment was there, but they want to still see the team. The problem, though, with telemedicine, as it was with COVID when people weren't coming into the clinic, is I can't do as well assessing respiratory status and functional status. We can kind of tell where you are with telemedicine. And, so it's, it is a little bit more difficult. Another challenge of multidisciplinary care is how long the visits are. We'll talk about that in a minute. And it really depends on how many different disciplines are available in the clinic. Ease of access. Absolutely. This is, I'm in North Philadelphia. I'm in the middle of the city, and sometimes getting into the city is difficult. And that gets back to some people choose to would prefer to do the telemedicine. But ease of access to the facility, space to do a multidisciplinary clinic can become a challenge for us. Uh, and then this resources for folks that we can give out. There used to be a lot more loan closets. So I order a power wheelchair, for instance. It can take, you go, you get measured, and you're waiting 3, 4, 5 months for that chair. What do you do in the interval if you need an aid, a device? Well, we in my center established a loan closet. We also loan out small equipment, and we give away activity of daily living equipment. But those are resources that we're fortunate to be able to have. They're not always available, and certainly they're not always covered resources. And we're lucky enough to work with philanthropy that pays for that and enables us to do that. And of course, everybody knows that DME is not always covered by your insurance. And so this is a challenge for both centers and for people living with ALS. We want you to have everything that's going to make you as independent as possible. And then the cost of disease to people living with ALS, and the cost of running a center. And in fact, after the webinar, if you're interested, you can certainly contact me. We're doing a large study, and we're looking at both of those aspects. Longitudinally, we're collecting data from people living with ALS and their caregivers about what did you need as time goes on, and how much is that costing you out of pocket, what's covered by insurance, and what are your preferences about your care. And we're also have a second part of that where we're collecting actual data from clinics. And we'll talk a little bit more about that in a moment in terms of what it does cost to run a center and how are we paying for it. So next slide. So, this just shows you that, clinic visits tend to be 3 hours or more in the larger multidisciplinary clinics. And the average number of professionals that you might see obviously goes up if you're in one of the clinics that last longer. So when clinics are, 2 hours, you see an average of 6 to 7 professionals. When they get above 3 hours, you're getting 8, 9, 10 professionals, an average of 9.2. Next slide. Thank you. How much does this cost the center? I mean, the total cost of my center, I estimated $757,000. You have to consider there are 3 physicians in our clinic, and they spend about 30% of their time on ALS, and that's where the physicians' salaries come. Nursing, we have a nurse that's her salary, and she works full-time on ALS-related issues. Our therapists, you can see it all adds up. Case management, the mental health and home visits, or research team, the support staff. We need our support staff, the space, and we figure it costs about $1,300 to give care for one visit. It's about $1,300. That's for one patient, one visit, and so that's a huge cost, and there are hidden costs. Yes, go ahead. You can move it on. Thank you. And so, how are people paying for this? I did this survey that I've talked about earlier. Go ahead. So, there are many ways. There's the direct billing. In my clinic, we get reimbursed of that 700 and some odd 57,000. My billing pays for. Are you ready? Yeah. I hope you're all sitting. I get about $140,000 of billing to offset that 750,000. For us, we have an MDA grant. There are several other granting agencies that also support clinics, philanthropy basically. My department eats it, a lot of it. Thank God Temple and my department in neurology is very generous. And we have a foundation, the ALS Hope Foundation, and a fund that also helps defer some of the cost. I use some of my discretionary fund, and then our clinical trials helps to defray the cost of some of the research team. Next slide. And when I ask my community, that's me. Okay, when I ask the community, how are you paying for your clinics? This is what everybody had more than one source. So, 53% of clinics did individual billing. 89% almost of folks relied on nonprofit and philanthropy. Think about that. Nonprofits, philanthropy are using the money they raise to subsidize insurers. That's basically what that means, because in my mind, insurance should be covering the cost of the disease. Departments and organization. One of the comments I got from one of my colleagues was because the next slide I think is our "Do you run at a deficit?" slide. 40% of folks were sure they ran at a deficit. Almost 40% didn't know. And my suspicion, they didn't know because they didn't want to ask because they knew they were in a deficit. Only 20% knew that they broke even. And that's nobody broke even without multiple sources of revenue. It isn't that they broke even on what they billed. They broke even by piecing together these different ways to pay for the clinic. So you can see that within the clinic system for us, we want to maintain excellence in care, but we're also very busy trying to make sure that we can keep whole our clinic. And one little anecdotal story, and one of the reasons I'm at Temple is I left Drexel when I went on vacation, and 3 of my team members were let go while I was on vacation because I wasn't breaking even. And so that stress and that kind of insecurity for your clinics is really difficult and will impact care, obviously. And all of my colleagues, along with me, our goal is to give the best care we can, the highest quality, and make you as independent as we possibly can. That's, we want your quality of life to be as good as it can be. And we know that we make a difference with multidisciplinary care. And that's why we do this. That's why we work so hard to keep it together. So appreciate your time. Thank you.
All right, thanks so much, Dr. Hyman Patterson. Excellent presentation. We're going to now talk about what we're doing about it. And with that, I'm going to turn it over to Joel Kartner. Joel.
Hey everybody, it's good to talk to you all again. We have a new bill. It's really exciting. We've been working on it for over a year, and we're really close to getting it introduced. So I'm really happy to be able to talk to you all about it. And I know, so to start off with, I'm kind of going to preach to the choir because all of you know exactly what this is like. But when I was talking to Dr. Sabrina Paganoni about, how do we pitch this to legislators, she gave me this story of a hypothetical patient in Maine. And it's proven very effective with members of Congress and their staffs to just kind of take them through a patient journey with these multidisciplinary care clinics. So I thought I would just do a version of that here, just so you can see how directly powerful your stories are when we talk about these things. So right now, the only payments that are reimbursed by CMS regarding care for ALS is when a patient sees either a medical doctor or a nurse practitioner. As you saw in Dr. Hyman Patterson's early slides, there's a whole lot of other services that get provided at these clinics, and none of them are reimbursed effectively. So let's say that we have a patient. His name is Mr. Jones. He lives in Maine, but his closest clinic is in Boston. And let's say at first, Mr. Jones is only coming down sporadically because he's early in his progression, and he just kind of needs maintenance care. But as his condition progresses, he starts to need to see a PT to get mobility aids, and he needs to see a pathologist because he's having difficulty swallowing, and then all the other things that begin to rack up over time. There's no reimbursement for those services in this Boston clinic. Um, and as Mr. Jones needs more and more services, he needs to come back down from Maine more and more frequently. So that's costing both him and the clinic more money as time progresses. Mr. Jones would, of course, have a local PT and a local pathologist, but as you all know, the people that are providing these services in clinics are experts in ALS. A local PT and a local pathologist, I mean, they're obviously amazing, well-qualified folks, but they're not going to know ALS like somebody in an ALS clinic is. So what this bill is going to allow us to do is better connect the PT that Mr. Jones has in Maine with the PT in the ALS clinic so that they can talk to each other more effectively, and get Mr. Jones better care without him having to come down to Boston over and over and over again. Paul, you can go to the next slide. So what does this bill actually do? And unfortunately, we've gone through multiple iterations, many drafts of this thing. And we actually just took out the title in order to give the staff and the member of Congress, you see her over there on the right, Representative Schakowsky from Chicago, we just took out the title in order to give them the right to name the title because it's their bill. So unfortunately, I just kind of have to refer to it as the bill. So again, just to reiterate, basically what this bill does is it amends the Medicare statute to create a facility-based supplemental payment system to qualified ALS clinics. That's a lot of words to basically say this bill allows for reimbursement for all of these other services that are not provided by a physician or a nurse practitioner. Beginning in 2025, qualified facilities would be paid $800 per visit for this bundle of services that's being provided, which, based on the math that we have, essentially allows clinics to break even for the services that are actually providing, which is great. It continues to support research in rural care and a lot of other things. So the idea is, if we have clinics that are actually being paid for the services that they're provided, then they can start putting resources into other things. Again, to reference Dr. Hyman Patterson's earlier slides, if you have a clinic that has wanted to bring on, say, a pathologist, but just doesn't have the money to do it, if they're being effectively reimbursed for the services they are provided, then maybe they can save up some money and get to hire that pathologist, or they can put more money into research, or if they want to become a clinical trial site, but they don't have the resources to do it because they're losing so much money, well then if we pay them effectively, maybe we can get them to a place where they can afford to do that. So all in all, you pay the doctors and hopefully that frees up resources for them to continue to make strides in this field. Lastly, we made sure to include a provision that seeks to hear from those both living with ALS, people caring for people with ALS, the physicians that provide these services, and organizations like ourselves to continue to talk to the secretary that's implementing these programs so that as medicine evolves, we can make sure that we're on top of it and that we're still continuing to offer the best care possible. So how can you get involved? This bill is going to be reintroduced very soon. I would put it at most a couple of weeks from now, and hopefully sooner. And when that bill is reintroduced, please contact your member of Congress and ask them to co-sponsor the bill. As Paul was talking about earlier, the Act for ALS was the most co-sponsored bill in Congress the year that it passed. Co-sponsorship has a really big effect on the chances for a bill because the more co-sponsors you have, the more obvious support the bill has. So there's more incentive to move it to floor votes and to have people talking about it, and of course to ultimately have the president sign it into law. So that co-sponsorship piece is so important. So once it's reintroduced, we will make sure to let you know. You can, better your chances of hearing about that if you join our advocacy network. You can do that at www.mda.org/advocacy. So we will make sure that you know when this thing is reintroduced, and then at that point, please do contact your congressperson and urge them to co-sponsor this bill. And with that, I think we can move into Q&A.
All right. Well, thank you very much, Joel. That was an excellent overview of the legislation that we've been hard at work on for a while, trying to solve this problem that Dr. Hyman Patterson, as well as Joel, outlined well. That does have a very real impact on those with ALS. Mark, thanks for putting in the chat that if you haven't joined our grassroots network yet, you see how you can do that in front of you here. That's mda.org/advocacy, or you can text MDA USA to 50457. And then just if you want to contact us with about this, or really anything for that matter, you can email us at advocacy@mdausa.org. That is the advocacy team with that inbox responding. So we do have a couple questions, and Dr. Hyman Patterson, actually, I want to kind of maybe ask you a leading question, if you will, that I have of my own, because some things we see frequently from those in the ALS community is, for one, an interest in some of the better genetic understanding of not only, of course, hereditary ALS, but the potential for underlying genetic underpinnings, if you will, of sporadic ALS. And then also from there, a really substantial interest in participating in clinical trials and participating in research. And obviously, at clinics, it's having a genetic counselor or a geneticist, or perhaps also having the ability to conduct such research in the clinics that allow for those options for the ALS community. So would this bundled payment help clinics offer those kinds of services to those with ALS?
Uh, it certainly would, because by having extra reimbursement, we can then contract a genetics counselor. I home grow them. Okay, so in my lab, my basic research is in genes that modify disease in mice that have ALS. And so several of my technicians have left the lab to go get degrees in genetic counseling. So I have a few people who are genetic counselors who worked for me at one point, who I contract with by the hour to do the counseling in the clinic. Getting extra reimbursement in the clinic will enable me to enlarge that. Luckily, to get the genetic testing now, there are programs that are subsidized by, for instance, Biogen subsidizes a program called ALS Identified, run through Invitae. So honestly, everybody who comes to me that has ALS is tested, unless they don't want to be, yeah. And I don't make people get tests, but I offer them the test. Because I do think that the genetic variants can differ in the way they express themselves even within the same family, and you may not even realize that other family members have had a genetic variant. So for instance, with the most common C9, some people present with dementia, some people can present with ALS, and so there, if you ask anybody have ALS, no, nobody ever had it, but yeah, they might, and we now know that even in this people without a family history, what we would term sporadic is the term we use, that probably upwards of 4 to 7% of those folks actually harbors one of the mutations, one of those 40 genes, most common C9. So a very important component, and yes, extra funding would enable us to enlarge our services, including genetic counseling.
Yeah, absolutely. Thank you, Dr. Hyman Patterson. In the chat here, Brooke makes a good point that certainly, many clinics are already doing a good job with this. It sounds, of course, like your clinic is, but then some clinics are not routinely offering or mentioning such services. And perhaps that is because they don't have the funds to actually have those on staff who have that expertise to provide that service to those with ALS. So consequently, having such a bundled payment, which we're trying to create as part of this bill, would allow for those clinics to have that expertise in-house, and there would be fewer individuals with ALS who wouldn't go unaware that there are some testing options, some other genetic options that they could be considering. Brooke also makes another point. It's going to be posed to Joel that there is a bit of an issue with genetic counseling not being covered more generally by
Yeah,
CMS, and that there is actually a separate piece of legislation that we're also working on, by the way, that happens to do with has to do with genetic counselors being officially covered providers under the Medicare program. Joel, I know you're hard at work on that. Any updates you'd like to give the folks here on that legislation?
Yeah, so there are actually a suite of 5 genetic medicine bills that we're trying to shepherd through the halls of Congress. Unfortunately, none of them have been reintroduced this session, but I've been told repeatedly by many, many offices that we should expect functionally similar versions of those bills. But as to specifically genetic counselors, there is a bill called the Access to Genetic Counselor Services Act that does just that. It covers genetic counselor services under CMS. So we're very excited about that whenever it does get reintroduced. Again, we're hoping sooner rather than later. And once it does, we'll be advocating in Congress to get that through for that exact reason of getting genetic testing is so, so important for so many different things.
Absolutely. So, Brooke, stay tuned for an Advocacy Institute maybe later this summer on that very topic as we talk about the genetic counseling bill, but also some of the other genetic medicine bills that we're hard at work on up on Capitol Hill. Dr. Hyman Patterson, we have another question that's kind of just more generally about ALS, and I'm sure this is one that you get fairly routinely. So perhaps you could answer this for the folks on the call tonight. But this is from Mark, and he asks just kind of a question on how often how long individuals with ALS will often live post a diagnosis, and then from there, are there efforts that are being successful in prolonging life of those with ALS? Anything that you'd like to tell the community about this evening on those kind of general questions on care for ALS?
sure. So everybody's different, and that's actually one of the important things, is to understand why some folks really can have a very prolonged course. We have 10% of folks live 10 years or more. 20% 5 years or more. And we all know the statistic that average is 2 to 5 years. And I tell the people I take care of, my job is to put you in that 10% that live 10 years or more. That's my job. And how am I going to do that? Well, I'm going to implement what drugs that we have now. There are 3 drugs available that slow the disease down in sporadic and without a family history. And if you do have a SOD1 mutation, one of those genetic variants that responds to the Qalsody, that's another new drug. But getting you on those drugs as early as possible, that's why early diagnosis is so critical. That will certainly prolong your life. And keep in mind that each of those 3 drugs is directed at a different mechanism, a different pathway. So I don't know in any one individual, I have no blood test or biomarker test that says, oh, you would do best on riluzole, or you would do best on radicava. Not now. That's what we need. But right now, I don't have that. So everybody gets everything if they want. It's always a mutual decision. I don't tell people what to do. I educate you and enable you to make decisions. That's important to me, that you have control of decision. And all along the way, I want folks that I travel this journey with, the folks that I care for, I want them to make decisions and feel like they have some control. And using all of the, support folks, my team is, everyone on the team is as important as I am. And while I'm busy managing secretions and maybe, implementing BiPAP, my team members are busy making your function as good as it can be and making you safe. And, keeping you from getting an aspiration is going to keep you living longer and feeling better. Keeping you from falling down the stairs and hitting your head by having safe ambulation is going to help. So that, and it's been shown that multidisciplinary care improves quality of life and reduces hospitalizations and improves survival. So all of that together, and BiPAP alone can extend your life if you're able to tolerate it and use it. And nobody should feel bad if they don't tolerate it, but if you're able to tolerate it and use it, it can add a year onto your life or 14 months. And that's also been shown that it extends life. So we have so much we can do while we're hoping for the next big drug to come along. And it's important to find somebody. And I'll also say that it's important to find somebody you're comfortable with. I always tell folks that, everybody has a style, right? Every doctor you go to has a style. Please find someone with the style that matches what you like, because you have to rely on each other. I rely on folks who I care for to tell me when something's wrong as soon as they can so I can help. And you rely on me to help you. So it's a team, and we're your extended family, and we need to work well together. All the barriers have to be down. We need to work well together so that we can help you negotiate this disease. I hope that answered your question in a long-winded way.
It was very comprehensive, but every word was important there. So thank you, Dr. Hyman Patterson. That was really an excellent response. And Terry in the chat says that they have a great team at UCLA that they like going to. So certainly having the right team in place, having the right clinician in place is very important. I'll just make one final call for questions in case anyone has one. As maybe you're going to type out your final question, I'll just add one additional note. I know those in the ALS community, those in any community for that matter, always like to see a really unified effort behind things of importance. And I can assure you that we're hard at work working very closely with our colleagues at the ALS Association, at IMALS, at a number of the other ALS groups, and of course, clinicians across the country on this legislation. So you will be likely not only hearing from us on this over the next couple of weeks as this legislation is going to be introduced, but you'll probably also be hearing from our colleagues and friends at our partnering organizations who you also likely work with and know well. So with that, I do see one additional question that just popped into the chat, and that is about NurOwn. And thank you for that question. I'll be happy to give at least a bit of a partial answer, because I think for many of us, we're all kind of just waiting and seeing what's going to happen as we look at Brainstorm and as we look at the FDA. So as we know, it was announced just a few months ago that the Brainstorm had quote unquote filed over protest their application to the FDA for NurOwn. And as best as we can understand that, because it's a process that's rarely used, it means that whereas FDA initially refused to actually review the application for NurOwn, that Brainstorm used the process to have FDA review it anyway. So that's, as we understand it at the very least, as far as I'm aware, and we do talk with Brainstorm fairly frequently, that's what's ongoing right now. That FDA is indeed conducting its review of NurOwn just as it would review any other therapy that would have its application filed in front of the FDA. And hopefully we will also be seeing more updates then on the timing of the advisory committee that would be tied to that review, as well as updates on when some major milestones in the review of that therapy will happen. Those are things that Brainstorm would be providing as far as would be aware. So we shall see. It could be an eventful year on that as well, of course, as we go along. So I'm just going to scroll through the chat to see here a couple other, yes, another comment or two about NurOwn and the AdCom there. Yes, about the Duchenne muscular dystrophy therapy that just had its advisory committee hearing the other week. Certainly impactful hearing. And then, of course, Terry, a mention of everything ALS. So they're good friends there, also colleagues there who we work with on that. So I think with that, I don't see any other questions in the queue. So why don't I close this out? I'll just say again, I'm very grateful for everyone's time in joining us this evening. This is being recorded, so in case you want to watch this again, maybe something you missed earlier in the presentation, you can always check the recording when we are able to post it on YouTube in a little bit. But in the meantime, keep an eye on that email, sign up for our advocacy alerts, because there will be opportunities to support this legislation. It's very important legislation for the ALS community here in the next couple of weeks. So with that, I'll bid everyone a good evening. Thanks again for joining us.